The single leg stance is a fairly straightforward test that we can do, but it gives us so much information. Remember the patient that was struggling to stand up from the chair. So now we're going to get them to do a single leg stance, which is, as it says and as it sounds, getting them to stand on one leg. And you bring this leg up, get them to really flex that hip. So the demonstration here is perfect. Now you'd get the patient to do this for half a minute. And as you're doing it, what we're doing here is following those two principles. We're looking at compressive and contractile load tolerance of that pelvis. Now, the glute med or the glute min, those things that we're assessing, oftenly are really strongly involved in pelvic control. And pelvic control is essentially diminished in this test if the patient cannot sustain that level of balance. So if we go back to that test now and get the patient to single leg balance on this leg and flex this side up, that level of diminished control is often referred to as a Trendelenburg. And with that Trendelenburg, what you often find is a bit of a pelvic shift and the pelvis will drop down. And as that happens, you start to increase even further that compression at that tendon insertion point. Now, as that patient is sustaining that single leg balance, what we're doing here is not only trying to identify whether they can do the test or not, but it's also giving us food for thought about what the back is doing also. So if you just rest back down there for the moment, if you have that patient standing here balancing on one leg and they've got a pelvic drop due to the Trendelenburg, then actually what I'm also trying to identify is what is the back doing? Because remember, the back might be presenting with symptoms as well. So if you have a patient that presents with left-sided lateral hip pain and you're getting them to do a single leg stance on that side and they cannot do it, well, one, that's a great starting point at us not being able to rule this possible diagnosis out. But the second thing is we're trying to look at all the other features that we can use, because you might want to treat the lower back as well. You know, you might need to think, well, actually the patient has a bit of tightness. If you stand on this leg again for me and balance on that leg, if the patient is maybe demonstrating features similar to this test when their gait is assessed, so whether they're leaning to that side to compensate or whether they're leaning towards the opposite side to try and compensate to offset the control deficit from here. Well, what that starts to tell us is, if you drop this leg down, perfect. What that starts to tell us now is, well, if they have any joint irritability from the back or muscular overactivity, well, even at that point, you're starting to be able to better clinically reason what you're going to do to the back when you're starting to treat it. Because what you don't want to do is have a patient who comes in with lateral hip pain, also has back issues as well, and you just throw them on the back, on the plinth and start treating the back without being able to rationalize why you think that back has become irritable or overworked due to the primary pathology that we're dealing with.